Okay, hello everyone. Welcome to Health 323 class. Today the topic is critical epidemiology and health studies. So within this topic, what we're gonna do is I'm inviting scholars in health promotion and critical health studies field to give us some examples of how the ways that we can incorporate critical health studies into epidemiology. So today we have Dr. Sophy Chan. Dr. Sophy Chan recently graduated from our program from SKHS. She recently obtained her PhD degree, and now she's a research associate at Kingston General Hospital. So we'll welcome you, Dr. Sophy Chan, and thanks for coming in to talk. So do you want to give our students a brief intro about yourself?
Sure. I'm really super glad to be in this interview today. My name is Sophy Chan, and a little bit about myself, other than my academic background. I'm a second generation Canadian. I was born and raised in Scarborough, but I have two refugee parents who came here from China in the late 80s. And yeah, I always introduce myself with this statement first because I feel like it's really important for me to always carry a piece of home with me. A little bit more about myself. I really like watching TV. Like, I'm obsessed with TV, and that's what I do in my free time now that I've done my PhD. And I really like to learn languages. So recently what I've been trying to do is I've been trying to learn Chinese again and reconnect with my roots, because a lot of kids growing up like me, second generation Canadian, don't know how to read and write Chinese. So that's what I've been doing lately. Sounds very nerdy, but I think I'm just like a lifelong learner. So that's a little bit about myself.
That's good. Thanks, Sophie. Yeah, learning a new language, I really like that too. But it's also very difficult. You need
It
to invest,
yeah,
you
yeah,
need
it's
to
like
invest a
hard to
lot of time.
master. Yeah.
Yeah. So you're trying to learn Mandarin Chinese or Cantonese?
No, I should learn Mandarin, but no, I'm learning Cantonese, and I'm just
I
learning
see.
like writing. I can
Right,
speak actually.
right.
Hmm.
Nice. Nice. Okay. Well, good luck with that. Um, yeah, thanks for the intro. So now it'll be great if you can give us a brief explanation of your training background and your disciplinary perspective, and your research interest in general.
Sure. So, I have a background in kinesiology. I did my undergrad at Western and I got a BA in kinesiology. And then I went on to do my master's in kinesiology, but focusing on the historical and sociological perspectives of sport mega events. And particularly, I was really interested in how that impacted marginalized populations. I took a year off to work in a nonprofit sports organization reaching out to marginalized youth in Toronto. And then I decided that maybe nonprofit wasn't for me. So I decided to go back to school, and I came here to Queens, and I enrolled in the health promotion program, because one thing I really enjoyed about my master's was trying to understand why people experience certain health outcomes, or why people experience, or how people get into spaces of marginalization. So that is a little bit about myself. Specifically, I have a background, it's really, really quite varied, but I would consider myself to be a social scientist. And my view and my take on health promotion is really colored by literature, from geography, from sociology, and from history. And I really think, for me, health, first and foremost, even though it is it is sort of about wellness. It's also about what are some of those social surroundings that are impacting us and our health. And I think my research interests, as I have already prefaced about my background, um, are really derived from my childhood experiences, actually. As I stated, my parents are refugees here to Canada, and when I was growing up, we had a pretty precarious living situation, and it was actually really tough. We had a really precarious housing situation, and when my parents divorced, I just lived with my mom, and I I our living situation did not improve, and in 2013, actually, she ended up having cancer. And all of this is to say that I saw really close up the social determinants of health unfolding in my life, and I didn't know it at that time, but I think, yeah, overworking, not having good job prospects, not having really good food security, like all of these things impact one's health. And so my research interests, though they are pretty vast, they're really surrounding this question of marginalization. They're surrounding a question of justice and how we can get to a space of equity for everyone. And so, yeah, it's a little bit about me and my research interests.
Yeah, that's awesome. Thanks for sharing that. Actually, in our previous topic, one of our previous topics were around social determinants of health when we were talking about social epidemiology. So we talked about, race, gender, food insecurity, and all those social issues that people experience that affects their health. So it is really great to hear that from a personal perspective. And thanks for sharing that.
Yeah, no problem.
Yeah, that's awesome. Okay, so let's moving on to the most important part of this interview. So can you tell us about the lecture topic? So it's about critical health promotion, and you briefly mentioned about what that is. So it's justice oriented, and it's trying to tackle the root causes of, people's health and the causes that affects people's health in a negative way. But can you tell us a little bit more about that and also how, yeah, just that.
Okay, I'll try my best. For me, critical health promotion is really about thinking about how the social context and also political context to which a person is embedded in really can impact their access and their ability to, and the ways that they experience health or receive help to having good health, and the ways that it impacts quality of life. And so today I actually wanted to talk a little bit about an area of expertise that I'm growing in, and an area of interest that really, really has grabbed my heart over the past few years, in order to explain what this might mean. So, as viewers have probably gathered, I don't have a background in epidemiology. So I'm going to talk a little bit about the context and then how an epidemiological lens could be applied. And so a little bit about my dissertation topic. In my dissertation, I talked about my dissertation topic really revolves around how people living in informal settlements, also called favelas in Portuguese, have been experiencing housing insecurity, and what are those implications on health. And so before I talk about that, I think I need to situate what an informal settlement or favela is. So a favela, the Portuguese word for informal settlement, really is has three defining characteristics. Now, important to know that even though it has three defining characteristics, no two favelas are the same. So it would be widely unfair to take a look at two favelas and say, oh, they're the same, and that informal settlements are prototypes of one another. That's not true. But there are three defining characteristics. The first one is that favelas are historically created by in precarious situations. So historically, it was created by migrants or slaves or people simply who could not afford to live in formal housing. And historically, what has happened is that people would literally find a plot of land and they would build on this space, literally using oftentimes crude elements like stone, brick, mortar, like whatever people could find. Number two, while favelas are pretty different, they all generally lack some sort of a social or physical provision. So many favelas do not have equal access to electricity, running water, sanitation, or government support. And lastly, almost all individuals living in favelas, but this is not all, do not have legal recognition to their land. So they don't have title to their land. And so what has really been problematic about this is that as the land value in Rio de Janeiro, and that's the place that I was living in and I was studying, is increasing, developers obviously want to develop and create new infrastructure. So what's happening is that people living in favelas who have no right to their land or legal right to their land are being evicted or face the threat of eviction on a daily basis. So then historically, the policies and actions towards favela residents have been rooted in racism, in sexism, and in classism. So favela residents today are predominantly Black, low income, informal workers, uneducated, and it was for a really, really long time a stigmatized space. It still is. And many favelas are also located in what scholars call urban peripheries. So if you've ever seen a map of Rio, you'll see that it's actually really hilly. And a lot of favelas, in a lot of pictures of favelas, you'll see that houses are kind of stacked on top of one another like that. And it's because they're on a hill. A lot of times they are also located in really environmentally sort of unsound places. So I've been to a favela which was created 50 years ago from what was a garbage dump. So it's really these spaces that are sort of not accessible, not really hygienic in sort of the formal sense. And so all of this is to say these racist policies, sort of the racialized view of favela residents, as well as the geographical isolation, has not been conducive to providing for the government to provide easy access to healthcare for these people. So all of this is to say that it's a challenge for people in favelas to receive healthcare. And so even historically and even today, like there are lots of communities that don't have fresh running water, a lot of communities that don't have regular trash disposal, and a lot of places don't even have like easy access to supermarkets. And so there's a lot of actually epidemiological studies about food insecurity in favelas and how it has like geographical isolation has led to a higher reliance on processed food and leading to obesity and diabetes and whatnot. And there's actually a really interesting article in the New York Times that was talking about how Nestle, do you know Nestle, like
the company,
corporation?
Yeah.
Like they hired door-to-door vendors and literally they have like a cart full of junk food to sell this food in favelas because they knew that access was an issue, like access to fresh fruits and vegetables. So all of this to say is that issues to like related to good access to fruits, vegetables, and also to healthcare is historically been a social issue and historically has been imbued in racism and in corporate greed. And so with this context, so happy, there has been a really interesting development lately in which, so as I said, like historically, favela residents have had really super high mortality rate, child mortality rate, and also like low life expectancy. In July, there was official statistics that came out reporting an extraordinarily low number of cases coming from favelas. Like it was so weird because historically there has just been a lot of health issues related to people there because of issues related to access and food and housing insecurity. But for an example, in July, in one of Rio's biggest favelas of over 70,000 residents, and like imagine it's the residents in the houses like this. Official statistics counted that there were only 12 COVID infections and 5 deaths in the whole community of 70,000 people, which is really, really hard to believe because, as we know, Brazil is actually one of the most heavy hit countries in all of the world, right? And so, and it's also really interesting to keep in mind that actually when you have houses that are so close together, because the houses are often created by hand, right? And they're also not created to code. There is a lot of overcrowding in favelas. So not only are people, I mean, is it questionable, but like if you look at a favela, like how are people able to practice physical distancing? Like it is so different, the dynamic. And also with people living paycheck to paycheck, like how are people being able to afford hand sanitizer and masks and on a daily basis? So, but for me, while these statistics are laughable, they're also not unexpected because historically, the census has never been able to accurately capture how many people live in favelas themselves. Right. And so you'll have an official count, which is actually substantially lower than some of the counts that NGOs and favela residents do themselves. And so an infectionist at the Federal University of Rio de Janeiro argued that while many of these deaths were registered, they were not identified to these residents. Right. And so it heavily altered the statistics of favela-related cases, like COVID cases. And for me, like this hits me hard in a critical sense because one, like not identifying an individual for me means to erase all of what that person is, like, and reduce them to just a person who died. But number two, it's also significant because it impacts the way public health departments will in the future distribute resources and roll out efforts to different parts of the city, right? So if they see that the statistics are low in favelas, why would they choose to distribute masks and sanitizer to those spaces? But it just doesn't make sense because historically, favela residents are the most vulnerable when it comes to health. And so I think having this case study in mind, we need to think really, really critically about what a solution for COVID-19 is in those spaces. So we think about the vaccine as a solution, but yes, it is. It's a biomedical solution. But when you transport it to that space, when there's issues with overcrowding, lack of education around how to sanitize, and in particular, it's a really, really close social culture. We need to think about the implications of what we think is a good public health solution. And so for me, thinking about this case, critical health promotion means to take into account all these different social, historical, political implications and context when thinking about Why do people die? Why do people get infected? And in particular, those who are silenced, right? What does it mean when some people are not captured under statistics? What does it mean for communities? What does it mean for a person living in a stigmatized community? And what does it mean for people who share similar race, similar class, similar income? All these things. So you can ask me questions. I just needed to get that off my chest.
That's great. Yeah, actually, I have a few questions listening to you, and the information is so interesting. And I remember I didn't go to that conference, but back in like 3 years ago, there was a big conference in Rio, and people went there, and they all everything that they talk about was that they are so struck by apparent inequality that exists in the city. They can just see that there's a big wall in between people who are privileged and not privileged, and like you said, like you described, the living situations that are not, you know, unacceptable. They're not acceptable, right? So that's very interesting. And actually, when I went to Thailand, I saw a similar situation. So there was a big, really fancy conference center that we were all in. And somehow we got into the other side by accident because we got lost and we couldn't. And there was a big wall, actually, like physical wall. And it was so hard to get out of that side. And all I could see was just crowded housing with just people with, you know, very distinct smell, and just people being, you know, apparently looking poor, right? So, you know, all these things, when you travel as a you know, person from the country like Canada, and you know, person with my I am privileged, right, in our society. So as a person who has that privilege, it's really hard to see those differences, and it's really hard to take, right? So as I listened to you, that really struck me. But at the same time, you said that from the epidemiological perspective, you said that the confirmed cases were only 12 and COVID-19 related death was 5. So that really doesn't make sense. But what's interesting is that then the mortality rate due to COVID-19 is over 40% in that population based on those numbers, right? So whereas in Canada, like I'm not sure in Brazil, but in most countries, it's the COVID-19 related mortality is lower than 1%. So right? So given that it's like 40 times higher in the population in Favela, right?
I think so. I think so I think there's several interesting points to make about that. So number one is that reporting from the perspective of a favela resident is a stigmatizing thing. So you think about it, a majority of people who work in the favela work in some sort of informal economy. So that means like probably like selling goods by the beach, or selling goods just walking along the beach. So that's a sort of informal economy. But sometimes they get gigs in formal economies, like cleaning for a club, or like working as a waiter or something like that. In those situations, there has been reports that a lot of people are afraid to report that they have COVID because they don't want to lose their jobs. And this is something really, really important that I want to say, is that when we think about COVID, just in our in our privileged lives, we just think, I don't want to get that infection because I don't want to die. But in favela spaces, there are more than one way to die. You can die from COVID, but even if you have the vaccine, you can die of poverty. And this is a real reality for people who don't have stable jobs. And a lot of people are like that. And it's not to look down, but it's to be sensitive to the reality that that death can happen in more than one way. And in that also, I like to push our understanding of health, right? It's not just about, just because I don't have disease doesn't mean I'm healthy. Like not having access to food, not having access to running water, that impacts health. And it seems to be quite indirect, but it is true. And so when people don't have access to running water, part of their income has to come out from buying bottled water, things like that, that we have to really, really think about when it comes to these sort of communities being hit by COVID.
And maybe for them, COVID-19 is it's not something special because their health is always under the threat. They could, just die from something else any day, any moment.
Like, that's a really good point. Like, crime is a real thing, and crime related to mortality is like very high in favelas, and as a result, actually, in favelas, child mortality is 5 times higher than outside of favelas for a variety of different reasons. It could be for respiratory problems, which does happen because sometimes these spaces are in environmentally unsound, like risky places, but a lot of it is also crime that people watch out for. So if it's like, so you're totally right. Like there's a lot of things to think about. Like COVID is not end all be all for people who are trying to, put something on their table to eat or to provide for their family. And another thing I want to say about the 40% is that the trend, because the trend was that there was a 40% mortality rate, like thinking about it, because people would not go to the hospital unless they were absolutely close to death. So that was probably why that was recorded versus a lot of people like underreporting for people who contracted but did not become hospitalized.
Right.
Yeah.
Yeah. And also, before we moving on to the next question, so people who live in Favela, do they have like birth certificate, like they get registered as a citizen, or some of them don't?
They generally, everybody does have a birth certificate, but not everybody has title. So a lot of times I've met a few people, like young people especially, who's come from pretty rural Brazil to try to make a living in Rio, and they end up living in favelas. So that sort of a history does not follow them. Their birth certificate would say their hometown, but then like their residence in a favela would not be recorded.
I see.
Yeah.
So they are basically homeless in Rio based on the paper.
Yeah, legally, like they don't have a place of residence. And also in a lot of favelas, there are no officially registered street names. Very, very rarely are they registered. So when I was in Rio, how I learned to get somewhere was looking at, okay, there's a gas station here, and I know 1 block down, there's going to be a hotel there. And then 1 block down, there's going to be a bridge. I have to cross the bridge. I'll walk through a garden, and then I'll get to like a huge wall, and I have to knock the door, and then inside is the favela. So a lot of times how I got to places was through recognition. And I think that's how a lot of people do it as well, like because it's not recognized by the city at all.
Right. Wow, that's interesting. Okay, so thanks for sharing that. And now moving on to our next topic. So you provided the research exhibit. Those are the 2 articles, and they are posted, or they're included in the course outline. So can you tell us on why? You already explained a little bit, but can you tell us why you chose the topic and what's the significance of it?
Sure. So as you may or may not be looking at right now, I'm choosing to exhibit the Favelas Unified Dashboard on Rio on Watch. So in the previous question, I talked about how there is severe underreporting for some of the huge, like biggest favelas in Rio. And so these 2 articles are articles written in English by by NGO that I worked with called Rio on Watch. Rio on Watch does a lot of really fantastic work on favela reporting. And one of the biggest things that they do, other than creating research, is that they they translate stuff from Portuguese to English. So all reports that are related to favelas and all written things. And so they actually have a series called Coronavirus Watch, and they are basically translating everything related to favelas. And so why did I choose this exhibit? So ideally for social issues, which I'm counting this as a social issue, like with regards to the favelas and the COVID situation, you would like the government to create interventions and policies to help individuals. This is generally what we expect. But historically, policies have not only failed this population, it has served to exacerbate the inequity around health and housing. And so in my research, in my personal research, I have found that favela residents and academics are actually combining activism and research together to force governments to get things done. And so this Favelas Unified Dashboard is exactly what that is. It's a collaboration between 20 community collectives, organizations, initiatives, and universities to create a space for robust COVID-19 reporting in favelas. And it's also a tool to allow the public to declare their own cases in a safe way. And so I think for me, the next frontier of healthcare reform is not with the governments, it's not with researchers themselves. I think it's in activism, and I think it's in collaborative effort. And I think for me, this is what this is the future of critical health studies. And I think also this is the root of how critical epidemiology came to be in Latin America, that there was a huge activism sort of movement to push health reform, because people are realizing that it's not just about numbers or reporting. People, like, there are implications for people, and that's why health reform is important. And so for me, I think this field of study is really, really significant. It's in the business, I hate using the word business, but it's in the works to change lives in partnership with people who are most affected. Mm-hmm.
Yeah, thanks for sharing that insight. I think that's awesome. So you mentioned that, there's a critical epidemiology, and this can be something, this can be a really good example of what critical epidemiology can contribute to in these collective efforts led by activists who are actually doing the work in the field. So, this class is epidemiology, and, some of the students will become epidemiologists. So do you have any suggestions to them in terms of, what they can do to be more, to do more meaningful work after they graduate?
Yeah, great question. So I see this way less in Canada, but I see this a lot in Brazil, simply because number one, governments do not listen to favela residents. I think governments do not think that they're human. Like, it's evident in their actions and stuff. And so what academics are doing is that they're partnering with people on the ground to make evidence, to make robust evidence to convince governments and force governments to act. And so this has been a long time tactic of governments, saying you're uneducated to favela residents, you don't know what you're saying, you're not actually experiencing the things that you're experiencing. And what epidemiologists are doing, and what other urban planners and lawyers and engineers are doing, are they're generating evidence to give people voice and saying, no, this is not true. Like, take a look at the statistics, take a look at what has happened in the past historically. This has happened to these people. And in a lot of cases, these collaborations have is actually what has pushed reform, housing reform, health reform, education reform in Brazil. And it is even more so relevant today within sort of our increasingly right-wing governments that are taking over the world. Like, evidence is key. So it's not just about the activism. I think there's a huge need to generate robust evidence. But the key point is, are we listening to the people who can actually provide us with the expertise? Are we listening to and working with people who have on the ground knowledge? And I think this is what is hugely missing in our today's academic world. Even myself as a researcher, am I listening to people who are actually affected, or am I just looking at some random literature? And so I think this is the relevance of students who want to become or have a career in epidemiology. Like, your contributions are important, but it's time to get out of that box, that traditional way of looking at things and data, and to consider other things as data, and to work with people. I think this is the future, I think.
That's a really great suggestion. So be political.
Yes.
Work for those who are in vulnerable situations. Listen to them and think about the research that you can do. Think about the evidence that you can produce to really achieve health equity, where all people can be healthy and have access to, clean water, just basic needs, human basic needs, clean water, shelter, stable income, access to healthcare, etc.
I just want to add, like, particularly in the context of Brazil and in favelas, there is power in being educated. And it sucks to say, but it is true. And we can use that voice to advocate and to help others. Or we can continue to be stuck in our same old ways and not progress. But like, super, super important to say that you have power, and moving forward, like, how are you going to use this power equitably if you are interested in health equity? This is like the huge question, because it begins with us. It's not just about data. It begins with how we're collecting data, how we're using data, and how we are seeing people unlike ourselves, and the ways that we want to help. And like, just another thing to add is that evidence will always be useful currency. Like, it just depends how you're going to spend it, right? So this became a very political speech, but it's true. I think health is political and research is political. So
yeah, I think it's great. So yeah, thanks for coming in today.
You're welcome. Thanks for having me.